Good morning, everyone, and welcome to our virtual forum featuring some key folks from the hospital and obviously our own Nick Paparella, who you can see on the screen with me right now. My name is John McFarland, and I am the President and CEO of the London Health Sciences Foundation, and absolutely delighted to host this event. This is a unique time. These are unique times, and therefore these are unique forums, I guess, in which we try and get out to meet folks and to talk about the great things that are going on in the hospital. On this, for the next hour, we're going to be having a discussion with some of the leadership at the hospital. Joining us will be Dr. Paul Woods, of course, our President and CEO at LHSC, Neil Johnson, who is the Executive Vice President and Chief Operating Officer, Dr. Adam Ducalo, who is Executive Vice President, Chief Medical Officer, and co-lead of the Pandemic Incident Management Team. Also, Carol Young-Ritchie, Executive Vice President, Chief Nursing Executive, Chief Quality Officer, and co-lead Pandemic Incident Management Team. You should see her business card. Dr. Doug Fraser, Pediatric Critical Care Physician, Scientist, Lawson Health Research Institute, and Children's Health Research Institute. And of course, everybody knows and loves our own Nick Paparella from CTV London. And we're delighted that Nick has agreed to moderate our panel discussion today. Thank you, Nick. You know, as I mentioned at the outset, these have been really challenging times, unprecedented times, in fact. And, you know, I get often asked the question, I've been over the past few months, are you surprised by the outpouring support by the community? My initial reaction is, yes, I'm absolutely surprised. But then I take a step back and I think, no, I'm not surprised. This is London. This is what we do. We step up in times of crisis. We step up when people are in need. And this has been no different in that regard. And for that, I want to say thank you to all of you who have joined in on this call and for the support that you've given, both financial and otherwise, to our frontline workers and to our hospital in general for a time of great need. And so I would say again, I'm not surprised because that is what we do and we've seen it time and time again. So thank you all for your support during this time. And we look forward to staying connected like this perhaps several more times over the coming months and as we get through this pandemic. The good news is we're seeing signs, positive signs relative to the pandemic. There is reason for optimism, but we can't take our foot off the gas pedal. We still have to stay strong and keep our distancing and mask wearing and all that sort of thing so that we all stay safe. Over the next hour, you're going to hear from special guests that I've already referred to. We're going to have a bit of an insider's view of LHSC during the pandemic, what's happening, what has happened, what we can expect down the road. And I know that some of you sent in some questions and they'll be addressed also during the course of the hour. And I think we're going to have a very enjoyable time. It's going to be informative and hopefully you'll enjoy hearing from our senior leaders at the hospital. Without further ado, I'm going to send it over to Nick, who is going to take us through this discussion. I'll be back in about half an hour when we have a short 5-minute break. And look forward to hearing the next speakers. Over to you, Nick.
All right, thank you very much, John. And you know, there's a lot of great reasons that I love being a Londoner and raise my family in this community. And one of those reasons, for sure, John, is our great hospital system. And through this pandemic, you know, it really shines through what these hospitals, what all of our hospitals mean to our community and how they have helped so many. So I'm very, very happy to be a part of this virtual special event. Right now, I want to call in the Grand Poobah of London Health Sciences Center, Dr. Paul Woods. Paul, how you doing? He's got his tuxedo on or something on there.
Yeah, Nick, I heard it was Donors of Distinction. I thought it was a little early in the day, but whoa.
It's a warm day out there, but you're all dolled up. You got the tux on. You're looking good, Paul.
Thank you. So.
Hey, and Paul, this is a very special event, and we want to thank a lot of the fine donors that help out year after year When the pandemic first hit, um, unfortunately with you, you had to step away at a very critical time from the hospital. For you, Paul, what was that like? It had to have been very, very difficult.
Yeah, it was not exactly the way it was scripted. So it was probably about 4 weeks into when we really thought things were going. And I had assumed a leadership role at the regional level and also in the provincial level. And I was probably working 16 hours a day or 18 hours a day, which a lot of people say, and I probably said it before, but this was the first time in my life I really was. And woke up on the morning of April 2nd and began a journey that anytime somebody says, that they do the undercover boss thing, nobody took it to the degree I did. And in a very short period of time, in a few hours, I went from feeling I was okay to realizing I was really quite sick, and had two major handoffs that I had to do. The first is one of our next guests will be Neil Johnson, and I called him late in the morning on April 2nd, not sure what was wrong with me, but sure that I was pretty sick and not able to continue. So Neil got dumped a global pandemic in his lap in a very short period of time. And then the second was to Gillian Kernahan, who assumed the regional role. And over the next 12 hours-ish, I went through a rapid decline and ended up in the emergency department late on the evening of April 2nd, which then took me on essentially a month-long journey. First, about 5 days in the hospital with, and I'm not ashamed to say I had acute diverticulitis. Treated, thought I was better, went home for a few days, and then ended up with a couple of abscesses. And under the very capable care of Dr. Neil Perry, ended up having some pretty significant surgery. And in total, I missed about 2 months. At first I wasn't sure whether I had COVID, so nor was the hospital, because at that point it was just, I was sick and it was sort of undifferentiated. So it was one of those things where I was essentially treated as if I could be. So I had an opportunity to be taken in as a potential COVID patient and seeing all of the sort of the things that happened with that. One of the things that I think was very compelling was how quickly one transitions from being, I've been a physician for 30 some years, 34 years, I guess, 35 years. And I went from being a physician and executive, leading this institution, to being this incredibly vulnerable and sick person. And I think what it did is it gave me this, I was no different from anybody else in my eyes. I was sick and I was scared. And so I saw that whole sort of, particularly that first, 3 weeks, through the eyes of somebody who was sick and scared. But one of the things that it taught me a number of things. One is we have a great organization. Right from the time I was met at the door of the emergency department to when I was discharged a few weeks later for the second and hopefully final time. What a great organization we have, and our teams are such committed professionals. Whether you're talking about physicians like Larry Brownscombe and Neil Perry, or the nurses, physical therapists, occupational therapists, etc., but the porters and the rad techs and the lab people and everything. It was just as a CEO, you want to know that the organization for whom you have the privilege of leading and serving in that way is actually providing a great product. And I was just incredibly compelled by that. And so it was a tough experience. I would not recommend it as a way of understanding one's organization. But on the other hand, I did have a great opportunity to learn from the inside what an organization we have, what are we really made of, the courageous caregivers that we have. So, I did have that opportunity to see what we do from a COVID perspective. And so, when I was met at the door, I was masked. Everybody else was masked on the assumption that I had COVID. And so that's how we've been dealing with people, is on the assumption that whether you're a patient coming in or whether you're a staff person coming in, you may have COVID. You may have the ability to pass that on. So, I've been asked, did I feel unsafe going to the emergency department? And the answer is absolutely not at all. There was no time where I sort of felt there was a breach in that. I was swabbed, and so once I was cleared on the floor, I was then one of the safe ones. I was allowed to remove my masks, but all of the staff still had to mask every time they came in the room because they represented a potential infectious threat to me. So, it was fascinating seeing how quickly we evolved from an organization that was not thinking about that sort of hyper contagious thing to, in a very short period of time, remembering this is early on, remembering that that anybody could be a potential bearer of the infection. So through the whole thing, it gave me incredible pride of the organization itself that we led, and I was proud of it before because of our many accomplishments and how others see us. But knowing that intimate, vulnerable, fearful patient experience, how we treat people, it made me much more so. And so I want to once again express my thanks to every member of the team. I love our porters. I keep calling them or giving them a shout out. They're fantastic, tons of personality. They make the experience so human. But really, everybody, the nurses, the one that insisted I get out of bed when I was arguing with her and lost the argument. Everybody all the way along, physicians, etc. And also to express my thanks and pride in our executive team. We're about 2.5 years into my tenure here, and we did have the opportunity to make some structural changes in that. And I would say if this were 2 years ago, we would not have been as ready as we were. We made a structural change, I think it was about 9 or 10 days before, in appointing Dr. Jackie Schleifer-Taylor as Chief Clinical Officer. And when I lobbed that hand grenade into the lap of that executive leadership team, they were so ready to deal with it. They did an incredible job as a team, and the vice presidents and the directors, everybody did a great job. And I think one of the great sort of endorsements that you're doing well as a leader is if your organization doesn't need you, and you've then made a robust organization. And during this time when our focus and sort of our commitment was to COVID patients, but also non-COVID patients as well, did an incredible job. And again, a special shout out to Neil Johnson, who very quickly became a CEO over a course of a 5-minute conversation, and I think did a great job. So thanks to everybody, and thanks, Nick.
And Dr. Wood, you're going to be back a little bit later, but right now we want to bring in the guy that helped you out there while you were gone. And Neil, how are you doing?
I'm doing well, Nick. How are you?
Good. Now you're a little bit more casual than Dr. Woods.
I didn't get the memo. I didn't get the memo.
For the tuxedo. All right.
No, my job is to make Paul look good, so I'm the contract.
You always do. Perfect. Now, you took over at the beginning of the pandemic, I mean, what was it like? Tell us just about how difficult and what kind of mountain you had to climb to get that put on your lap.
Well, as Paul said, he called me on April 2nd, and I'd like to think that it was just another day at the office, but it probably wasn't. I was actually sitting in the same chair when my phone went off, and I was meeting with somebody and stepped out of my office, went down the hallway and took his call. And, a couple of things jumped to mind. First of all, I'm worried for Paul. I want to make sure that he's okay. And that was part of the conversation for sure. And afterwards, when I started telling people that Paul was ill and was going to be off, that was the immediate concern of the executives around the office as well too. But from then on, it was, I have to say, Nick, it was absolutely seamless. I enjoyed great support from my executive colleagues. Within that first day, it was like, what do you need from us? And my response was, I really don't know right now. And as Paul has said, there's an initial stage when he thought he might be back within 2 weeks, and then that stretched out to 2 months, and there's a little bit of a different tenor right there. But it's like they talk about in sports teams. If somebody goes down with an injury, it's always the next man or next woman up, right? And I think that's the way that people approach this. You had to make some quick decisions around reapportioning some work and so forth. But one of the great things about working at London Health Sciences Centre is the people that we work with, and sometimes that seems a little bit trite or perhaps a little not people don't take it for granted or whatever, but huge support from people like Carol and Adam, who did a fantastic job, Jackie, Susan, our chiefs, medical chiefs, all the leaders all the way down through the organization were great. So I'm still here, so that's good.
Good. And Neil, tell us about the day-to-day operations, the way how things went from day to day during the pandemic.
Well, really, this is what we had done even before Paul went off sick, is that Carol and Adam were really calling the shots around how we were managing our pandemic response. We kept getting notices and edicts and directives from the government because we're under a state of emergency. So their job was to, and you'll hear from them in a little while, it was to run our incident management team. Jackie and my role and Susan's role is really to keep a lot of the other operations going and make sure, as an example, that as we ramp down operations, clinically, that we were managing the quality of those as well too, and keeping track of those. So really, a lot of the day-to-day was driven by government directives, then sort of circulating 24-hour plans where our pandemic incident management team would tell us sort of what the next stage of work that we had to do, and directing that. My job sometimes felt like just being a air traffic controller, making sure that everyone's doing their work and or at least coordinating things. Obviously keeping the board up to date, but also playing a role in communicating with our community, donors included. Because, you know, if you reflect back to March and April, the sense that we have now is a lot more frenetic back then than it was now. People were scared. Our health workforce was scared. Our community was scared. And our job at that point in time was to communicate with our community that we are going to be there for them. And that was our primary job. That was one of the first things I did in communicating to the staff and physicians. Was our primary job is to make sure we're ready to serve our community. That's our only job at that point in time.
And Neil, you're right. Everyone was kind of on pins and needles. We've never been through a pandemic like this before. Tell us about the morale of the staff and the physicians when this first broke, and what's their morale like today?
Well, and I'll ask Carol and Adam to talk to that as well too. But I mean, early on, as I went out in the organization and did tours around, you know, the early days, I think people were scared because, you know, of things like have enough of that. They saw what was going on in New York City and Italy and other jurisdictions, and it was quite scary. And then when you talk about setting up a field hospital and Western Fair and so forth, people all of a sudden realize this is big and it's real. So I think overwhelmingly it was uncertain and scared at that point, early point in time. And of course, people were coming back from March break. They had to quarantine at home. They didn't know whether they were going to be safe. Schools had been canceled. So you forget that, or I don't want to forget that people have lives outside of the work, and that really impinges upon their ability to do their work as well too. Now it's changed. You know, I think people have, they're probably still somewhat tired, but the tenor as I've gone out of the organization over the last few weeks is changed to saying, okay, we got this, and we're far more confident. And then comparing with other jurisdictions that are still having struggles, you know, we've got this and we're making progress. And a lot of that is the support that we've had from the community in dealing with pandemic prevention measures, as an example.
And Neil, what about communicating with the public? What about getting the word out that just about what the status is at all the hospitals?
Yeah, that was one of the early things, Nick, that I really focused on, because we early on were just really so inwardly focused because we needed to be. But our early messages were, again, that confidence that we've got this for the community. We also partnered with St. Joseph's around communicating, being authentic about the impact that this has had on people who are waiting to hear from you and are waiting to get their care, and it's been delayed. And so, you know, we were about that. And then also the other key message that we did early on was it's safe to come in. As Paula said, if you need urgent care, please come in. And those were some of the key messages that we delivered. And we saw the community respond to that. After we did our messaging around it's safe to come into the hospital, lo and behold, our emergency volumes went up. And that's a good thing, because we're here to serve the community.
Now, LHSC built a field hospital at the Western Fair. What was involved in getting that field hospital operational, and why was it so important, Neil, to set that up?
Yeah, at the time, we were all worried about capacity in the organization. So we tripled our intensive care unit capacity. We're worried that we wouldn't have enough space to deal with patients and care for them. And so this was felt to be an option where we could care for COVID patients who were recovering, but who couldn't go home at that point in time. And so within sort of 10 days, we stood up about 150 beds in a field hospital situation. Depesh Patel, Derek Lal did a great job of the facility side. Dr. Vivian McAllister and Dr. Ian Ball, who have great military background, helped us with that as well too. I've got about 40,000 square feet of vinyl flooring that I'll need to get rid of after this, but so we'll have a little bit of a sale on that. But they really constructed things and moved things very quickly around that. And you know, it's not a real hospital, but we're very fortunate to have the partnership of the city and Western Fair to make that happen. And again, it was really to create that capacity. As I said to the staff and I said in the media, you know, our biggest goal here is to build it and never need it. And so far we haven't needed it, so that's great.
Now, the flooring isn't part of the equipment, but what kind of equipment was needed to set up that site?
Well, everything. I mean, we didn't, at that point in time, it was almost impossible to get real hospital beds. So we had people constructing beds that could tilt and lean and so forth. So there was that part. We needed and had to order portable x-ray machines, oxygen provision, all the types of things you'd need as in an organization, medication dispensing, et cetera, right? So wasn't as extensive as you see in the hospital because we wanted to have it light touch care, but a lot of those types of things that you see in a hospital, you'd actually see there as well.
Okay, Neil, we're going to have you back in a bit, but right now we want to bring in a couple of others. Thank you for that, by the way, Neil. We'll have you back in a bit. We want to bring in Carol Young-Ritchie and Dr. Adam Duclos. How are you doing, guys?
Great.
Great,
Good,
Nick.
good,
Thanks
good.
for having us.
Good. No. This is great. This is so much fun to let everybody know just the progress and just how everyone's doing these days, especially when hospitals are on everyone's mind. Now, guys, you guys explain what the pandemic incident management team is, what the role is, because that's really what you guys took the lead on. Explain that.
Yeah, thanks very much, Nick. You know, traditionally, whenever our hospital has a major incident, such as a long power failure, those types of things, we pull together an incident management team. And in general, it might last a few hours or a few days. This one has lasted 6 months. So our pandemic incident management team pulled together specific groups of leaders that really took over operations in a number of areas for the hospital and have been for a long time now. Specifically in early March, this was ramped up, and we had to have groups like our infection prevention and control, our operations group looking at process and protocols, new care maps, logistics for things like personal protective equipment, screening, distancing, signage, facilities. You know, you can imagine even with not allowing visitors in the hospital but people still having to come, we had to put porta potties on the outside of the hospital so people could use the washroom while they're waiting for their loved one to go to an appointment. Our planning group looked at for human resources redeployment. So people that would have worked in one area got moved to another area of the hospital specific to the pandemic during the response. Communications. So for a number of weeks, we had all staff. We've got about 14,000 staff and physicians at the London Health Sciences Center, and we were communicating 7 days a week with them for a period of 6 or 7 weeks. Now it's down to one time a week, but it was very frequent. So our communications team was involved in that. A liaison with a citywide emergency management group, and then also some regional involvement. So lots of leaders coming together on a daily basis for an hour or more, 7 days a week initially, and then down to 6 days. And slowly we've ramped it down to 1 day a week currently.
Okay, now what did the PIMT do to prioritize staff and physician wellness throughout this pandemic?
Yeah, so we put a lot of focus on staff and physician wellness. So one of the things we did right at the start was put together a wellness task team. So as you can appreciate, well, we want to take great care of our patients. We also really want to take great care of our staff, and recognizing that our staff, as they come to work, have complex lives outside of here. So things like childcare, elder care, things like that, and how are our staff going to get the supports they need so they can come to work and work here. So we put a lot of work into that. We had a number of community organizations, hotels offer space to us. So we helped to facilitate some of those things for our staff. So people, some of our staff chose to stay at a hotel for the duration of their work time so they could protect their loved ones at home. many of our staff have small children at home because all the daycares were closed. So we had a number of resources for our staff to link in with daycare to support them at home. So when they came to work, they weren't worried and they could do their jobs. We also set up extended occupational health and safety hours for our staff. So we ramped a 24-hour call for our staff so we could have their questions about their health answered very quickly. And we also launched, as Adam was saying, communication was really important. So we had a COVID line for our staff, and it was an email line, so where people could ask questions and we could get those questions answered with them very quickly. So again, there was a lot of fear in our community too. We wanted to decrease that fear for our staff, so when they came to work, they felt safe. We did a wellness survey for our staff just to have a baseline for where we were at. One thing we heard from our staff that, you know, being in the masks and the PPE all the time was stressful. So what we did in our organization, we created some quiet spaces for staff so they could get away on their break time and their meal times, just to get away to collect their thoughts and have a quiet place, just to be quiet before they went back to work again. We also really focused on communication. So Adam and I launched something that's new to our organization, was virtual staff forums. So we would get on a forum just like this, and Adam and I would lead those and answer questions that were important to our staff that we heard from. And what we coined a phrase was part of our forum was about, as we talk about caring for staff, we also said caring for you and what can we do to care for our staff more. So we did a lot of those types of things. We also ramped up some of our staff fitness. So we have virtual staff fitness. And really looking at how to take care of people during this time. We went to the literature, we had a lit review done that looked at, you know, how do people cope in major events like this. So we learned a lot from SARS. And what we do know from looking at that literature, that the event isn't over yet, that this is still top of mind for a lot of staff, their safety, how they're managing at home. So we continue with staff wellness and continue to look at how we can support our staff. Likely over the next year, we're going to have to do that as we go through this uncertain time.
Now, you kind of addressed a lot of them there, but what were some of the challenges, maybe the early challenges that you had to overcome?
Really, it was around PPE. Staff quite worried about PPE, and you know, were we going to have enough PPE?
Yeah, and I'll pick up on that as well, Nick, if that's okay. You know, I think the unknown was probably the greatest challenge. The unknown about the virus, how to protect our staff, and how to take care of our patients and protect them as well. Carol mentioned communication. That was a big challenge. We had lots of conflicting evidence and guidance from medical societies versus what the government was saying versus what IPAC was saying. And that was, you know, rightfully so. Things were unknown, limited testing capacity. And one that is still front of mind is the decisions we had to make to delay care. So without knowing what the right safety measures were and how much capacity we were going to need to care for COVID patients, you know, as you've seen in the paper, we had to delay care for non-COVID patients. So that was a big challenge. It's not easy for clinicians and or leaders to make those types of decisions.
Now, what are you most proud of, guys? There's got to be a million things. What are you most proud of right now as we continue on with this pandemic?
Yeah, I would really say, Nick, it's really how our whole organization came together to battle this. There was a lot of scary times, and how are we going to manage this? A lot of unknowns, but I would say our whole organization rallied together, and you know, our goal was to take care of patients and what was ahead of us. So that's really what was most proud.
Now, operationally, you had to make some big decisions. What decisions needed to be made to keep patients safe during this pandemic?
Yeah, so it was the decisions that had to be made and the pace they had to be made at. And so the pace was quick. We're talking hours, information changing, but the decisions were around things like who to provide care to and how to provide that care, who to test when you have limited testing. So in the early days, we had very limited testing, a couple hundred tests a day that we could do. Thankfully, just great work through our lab, we're up to 1,300 or 1,400. It'll be up to 3,000 soon. But those were challenging. And who had access to what facilities and what PPE. So with limited PPE, we're literally having to say no to some people as to what PPE they could have as providers. And then when to resume scheduled care as things moved on, as I mentioned earlier.
All right, thank you very much, guys. We're going to have you back in a bit. We're just wrapping this portion up, and thanks, I think Nick. We're going to now throw it back to John. John, are you there?
I am, Nick. Thank you very much. And we are going to take a quick break here, 5 minutes, and but we're going to show you a video. We'd love to have you watch this video expression from our front line. So enjoy the video.
And what a very, very inspirational video. Our hats go off to all of the staff, physicians, frontline workers, and as Dr. Woods mentioned, the porters even at the hospitals. Very, very inspirational, and that's why I'm so proud to be a part of this community. We want to welcome back Neil Johnson now. And Neil, tell us about the community. The community has come forward with donations, not only monetarily, but with masks and so on and so forth. How has that helped the hospital staff?
Well, it's been a huge source of both, I guess, operational relief for us, but also just encouragement, right? When we first started in this, I remember talking with John and then Scott Fortnum over at the Children's Health Foundation, because they were marshaling resources and donations and so forth. But we were getting inundated with, can I offer you this? Can I offer you that? And of course, Shannon Digby stepped up and is the key point person from London Health Sciences Foundation that's been fielding all those calls. And, our approach was, no gift is too small, and, we're not sure whether we can use it. Please let us know about this. And, the biggest one clearly was personal protective equipment. We had all sorts of donations, and you think of, medical communities like dental offices and so forth, but industry, private individuals had some, they'd bring it in. We had a stockhouse or a stockpile at the Western Fair as well, too. We were receiving things there. So that was huge. That got right to our frontline providers right away. It was great. But then the financial donations, we're a lot of equipment that we had to buy things in the early days, which we had to go very quickly and get, were things like glide scopes, which help with when we need to manage a patient's airway if they're having breathing difficulties and intubating them. This also helps the patient, but it protects our staff as well. So those ones were hugely meaningful. And then things like gifts of offers of food and donations of dinners and lunches. Sometimes we couldn't take them in because we were very restricted at one point in time. That's lessened up a little bit, but each one of those really signaled a great thing to our community, or from our community. But even beyond that, I mean, the fact that we knew our community was with us was huge. I remember tweeting out as I'd go home and walk around the neighborhood. Nick, in our neighborhood, you'll know there's a few sidewalk chalk artists around our area, and they had lots of encouraging messages for healthcare workers. I came into the hospital, people have been leaving painted rocks and encouragement around the UH emerge department, and then the various signs that we had put up around the organization, the patient people who came in fire trucks and other vehicles to have parades around the organization. It's not monetary, it's not a gift of equipment or anything along that lines, but that gift of encouragement was just so important at that point in time for us.
And Neil, that's got to make you feel good.
Yeah, it does. Sometimes, hospitals soldier on and don't try to get the limelight. We're supposed to be there when people need us. We're not trying to get any glory in this, but to really know that our community appreciated what was going on and spoke volumes, I think, to how we were serving the community. And I think it was a point of honor and pride for our staff to feel that recognition. I know I felt great about it, not me personally, but for our organization, that we're putting out our level best and our community is responding.
And Neil, you should be very proud. Thank you very much for this.
Okay,
we'll
be well.
In a bit, but all right, we want to bring in Carol Young-Ritchie back again. And Carol, there've been a number of safety precautions that are in place at LHSC to ensure the well-being of everyone, patients, frontline staff, and our community. That being said, clinically, tell us what the future looks like for patients visiting the hospital or undergoing even surgery at the hospital.
Yeah, so we started to see some of our elective work come back. So we had a time that we were quite restricted. We always did emergent and urgent surgeries and care that we needed to provide. So that was always part of what we were doing through the pandemic. But over the last month or so, we've started to increase some of our ambulatory work and some of our elective surgeries. So what you will notice as people come back to the hospital is that we are very strict on screening. So all patients and visitors come through screening, and we screen for COVID. For patients who have scheduled visits to our ambulatory areas, we will call people 72 hours before their visit, again, to do a telephone screening before they come to hospital, just to make sure that we're keeping patients safe and we're keeping our staff safe. So patients will come in. And we're also putting in place physical distancing. So as you see that out in the community, we're also doing that here at the hospital. So what we're trying to do is schedule our visits so we maximize our physical distancing in our waiting room. So you're not going to see packed waiting rooms as we used to have. So we're being very cautious around that and making sure that we're bringing people in and can keep everybody safe. Right, we are ramping up some of our surgeries again. So again, our physicians are triaging those surgeries. We are a bit behind from the elective work that we had to stop doing. So we are triaging those cases, and our physicians are doing a good job at screening patients before they come to hospital. And perhaps some of those patients, the high-risk patients, will be getting swabbed before they come in. Again, just to make sure that everyone is safe before they come in.
And Carol, what about those the elective surgery? What's the status with them?
Yeah, we're starting to bring that back up again. We're about 80% of where we were before. So again, what we do is we look at all those elective surgeries, and we're also working with our region. So every week or every 2 weeks now, we submit to our region to make sure that we're all ramping up our surgeries at the same pace, and that we're certainly getting to those patients who need to be done urgently. So making sure that that's fair across our region.
All right. And what will patients need to do before a visit or before surgery?
Yeah, generally it's screening. So they can expect a call from us before they come in, and we'll screen for some of those COVID symptoms, and our staff will direct them from there. So that could mean some testing. It could mean a virtual visit. So we've moved to virtual visits. So sometimes we're trying to avoid people from coming into hospital. So when that's appropriate, it might be a telephone or a video visit that we have with patients instead of coming into hospital.
And Carol, these changes, this is probably the $1,000,000 question. How long are these changes expected to be in effect, I guess?
Yeah, that's really hard to tell. We are predicting well into the fall and the winter. So this is likely to be with us for some time. And we continue to get direction from the Ministry of Health about any changes that we need to make as the situation changes. But we're likely to have screening for quite some time. And we're looking at how we can reimagine our care too. Like I said, things like virtual visits and again, keeping everybody safe.
All right. And Carol, at this point, we want to bring in Dr. Duclos as well. Now, with all the precautions that you've already taken, everyone is kind of expecting a second wave of COVID-19. If one does come, and that's what everyone, what's the anticipated time frame with that?
Yeah, certainly we're collaborating very closely with the health unit and Dr. Mackey and Dr. Summers, and as well as other regional partners in the province. It would likely be September, October, at least that's sort of the best educated guess at this point in time. But there's a number of factors that play into that. You just have to look at the numbers in Israel recently to see that they had almost eliminated cases on a daily basis. And then opened up probably a little bit too quickly in retrospect, and now they're back up to hundreds or even close to 1,000 cases a day. So, but in London here, we would be looking at likely September or into October, early November.
Are we thinking that the cold weather has something to do with this? Is it the fall, winter kind of thing?
No, it's more in terms of timing. So every action that happens in our community, it's a 2 to 3 week delay before you're going to see a spike in cases, and a further delay before you see a spike in the hospital. So given the staged approach, which is very, very appropriate that our province has taken to opening back up, we're not even at the most open stage yet, right? So there also is the impact of schools opening up. And less people on vacation, so more people congregating within the cities. So those are all factors that give us that timing. But it's best an educated guess.
And guys, what are your thoughts about preparing? Any additional thoughts on preparing for this second wave?
Yeah, just a few things. So all the resumption of services that Carol has talked about is being done within the constraints of personal protective equipment, the space or hospital beds that we have. So keeping 10% of our beds open or easily open for COVID patients, making sure we have the drugs, and frankly, purchasing more and more personal protective equipment as much as is available. You can imagine that's challenging. A lot of it's being used south of the border and even being detained within the US and the UK. But those types of preparations are well underway, and we've got some great teams working on it.
All right. Thank you very much, Dr. Duclos. Thank you, Carol, for this very, very informative. We want to bring in, and you talked to Dr. Duclos about drugs, I guess, and we want to bring in Dr. Doug Fraser here, who's going to talk about something that would affect everyone around the world, and that would be a vaccine and how the virus has affected millions and millions and millions of people around the world. How you doing, Dr. Fraser?
Good morning. I'm doing great.
Now, what information can you provide us with any recent research at LHSC with the Lawson Health Research Institute? What findings and what can you tell us has been going on?
Sure. Well, there's a lot going on. I think at last count, there was something like 70 studies going on in the city that are either underway or being planned right now. So there's a lot going on. Back in March 15th, I think it was, when our first patient with COVID-19 came into the ICU here in London, we saw what was happening around the world. We have the infrastructure and the people here to make a mark on things. And we got everything prepared very, very quickly, including ordering supplies and getting ready to go. And we were first out of the chute to get things going, and it's paid off very, very well in the sense that there are three, outside of the vaccine issue, there are three important questions that needed to be answered with this disease. The first is, how the body reacts to the disease, how the immune system reacts. The second is why patients are suffering from blood clots, which is occurring in the sicker patients and taking lives. And the third question is, could we develop some sort of markers to determine who's going to get sick and how they're going to do overall? And we prioritize those questions here in London. We went to the London Health Sciences Foundation and said, you got the best people in the world here. We're ready to move. We've got the expertise. We just need a little bit of funding. And they stepped up immediately, as did our partners. And the first question about the immune response, we've already answered. You may have seen that in the media recently. We were the first in the world to immune profile or do inflammatory profiling of the patients with COVID-19, and that's opened up 6 therapeutic targets that are now being considered for clinical trials. So with everything going on so quickly, a lot of people are guessing and they're jumping on things, and we've seen a lot of medications being thrown out there, particularly south of the border, out of primarily desperation. We took a different approach. We spent a couple of months working hard with our patients, taking blood samples and testing, and now we've come up with some rational ideas of what to go after. And proud to say that our first publication is now ranked in the top 1% of publications in the world, and it's #1 in the journal, and it's taken off right across. The second thing we've gone after is why people are suffering from these blood clots, and in fact, that's going to be published in the next few weeks. We are the first in the world to determine why that's occurring, and we'll be putting out recommendations on how to deal with that. When we found out that your blood vessels, the interior lumen of your blood vessels, have essentially been sheared off by this virus, particularly in the pulmonary vasculature, the vasculature of your lungs. And there are methods to deal with that as well, much more effectively than what we're doing now. And the final thing, which is also coming out in the next 2 to 3 weeks, is we have discovered 10 what we call biomarkers. These are proteins that float around in blood. And these 10 biomarkers predict with 100% certainty which patients are unfortunately going to live or die. And that's very important, because if we can understand on day one who is going to get sick, we can now mobilize resources. We can have appropriate discussions with families about goals of care and so forth. So that will also be coming out shortly, and I think that will get worldwide attention as well. And this all came to fruition because you've got the people here in London. It's small enough we can work together, but it's big enough we've got everything we need. And we saw an opportunity in the darkness, and we took it, and we nailed it.
And Dr. Fraser, tell us how important donor funding is for the research and for the Institute.
Right. So just to tell you what's going on now, people are struggling right now in the research world because the supply chains have broken down, and the borders are closed. So trying to get the supplies you need to do what you need to do is very, very difficult. We saw that early on, and we immediately went to the London Health Sciences Foundation and partners, and we said, we need money now. We can nail this, and that money was provided to us without hesitation. And because of that, we're leading the world right now on several fronts.
All right. Thank you very much for this, Dr. Fraser, and all the best. Thank you very much.
My pleasure. Thank you.
All right. We want to bring in back Dr. Duclos to talk about COVID-19 and what with no cure available, what are the protocols, what are the options for care for patients with COVID-19?
Yeah, it's, obviously you just heard from a now world expert in Doug talking about the research that's going on in London that will hopefully direct, effective therapies for COVID-19. At this point in time, our therapies are focused on what will be termed supportive care. So providing oxygen, protecting the airway, trying not to infect other people. But we did do a lot in that arena over the past few months. Our anesthesia colleagues under the leadership of Dr. Yang, emergency medicine with Dr. McDonald, and critical care, Dr. Hedera, set up what's called intubation teams. So we had docs with the most experience in securing an airway or putting a breathing tube in, available 24/7 in-house at both University Hospital and London Health Sciences Center, in order to make sure that was done as efficiently and as effectively, safely as possible. We've got protocols in place for screening before surgery for certain populations of patients, because it's been shown that if someone is operated on with COVID, their outcome isn't as good as without it, and that's even if the person doesn't have symptoms. Thankfully, we're in a low prevalence state right now, so there's very, very little COVID in our community. And lastly, one of the things that's important from an operations perspective is around being able to detect that second wave and forecasting and modeling when it may come, and being able to do that based on a small bump in cases. In our community, even if we went to 7 or 8 cases in a single day, that would be significant and would be a signal that a second wave is coming. So we're working with Ivy Business School and a number of others and epidemiologists to see what the best way to do that surveillance is. So yeah, there's lots of work going on, and I congratulate Doug Fraser and his teams for all the work they've done, because that will really be the way of the future in treating this disease.
All right, Dr. Duclos, thank you very much for this.
Thanks very much, Nick.
All right.
You too.
We want to bring back in the tuxedo man, the Grand Poobah. He's still wearing the tux. So there you go. He's looking dapper still to help wrap things up. And Paul, with all that you've heard, it's got to be comforting to know that we live in this great community with great hospital care and great staff. Now, LHSC is being the largest acute care center in Southwestern Ontario and significant research being done in London. What role does LHSC play locally, regionally, and globally, Dr. Woods, in regards to the pandemic?
Yeah, thanks, Nick. And I think you've heard a lot of pieces of that over the past 50 minutes. And I think it bears mentioning that while we are a large academic health sciences center, we also represent by far the largest number of acute care beds in Southwestern Ontario, west of Hamilton. And so we are a huge provider for patients, whether they have something very critical and very esoteric or something that is just regular run of the mill, like community acquired pneumonia and that sort of thing. So we are a huge acute care provider, as something that we do extremely well, and we continue in that mission. If you look at our emergency department in terms of the number of people served, not even just in our primary service area, but when other places are having trouble with access and that sort of thing, we take the overflow. Again, from an inpatient perspective, we're also the backstop for a lot of smaller hospitals who may have trouble with staffing, whether it's physician staffing or nursing or other non-physician staffing, clinical staffing. And so we often present the sort of the backstop for all of those things. I think one of the things that I'm very proud of, and I actually, not because of my own experience, but after we were committed to this, was very proud of the fact that we sort of put a stake in the ground and made a commitment that non-COVID patients were also going to get the same great care that they always did. And one of the mental errors that I saw happening elsewhere in the world was that people were so freaked out and absorbed with COVID. There was almost a forgetting that people are still going to have heart attacks and strokes or acute diverticulitis, and they're going to get sick with it. And in some places, they're going to die of it. So we really early on made a declaration, including making some structural changes within the hospital, and pointing out that in places like Lombardy, Italy, or in New York City, or where my daughter is a nurse in Detroit, many people without COVID but who had serious illness died merely because the system was overwhelmed. So I think we did a fabulous job of keeping that going, and we maintain that commitment, and we are preparing for the second wave, as was alluded to earlier. From a regional perspective, there are a bunch of clinical things that we do. Again, Dr. Fraser talked about, the researchers doing, but he's doing, and his teams are doing, but the Children's Hospital and Maternal Child program in terms of supporting, pregnant women and newborns and children all across the region. And so we do all of those sorts of things from a critical care perspective. I think Neil Johnson mentioned that we essentially tripled our ability to manage patients who are critically ill on ventilators, because that was the lessons learned from elsewhere. The other thing that we did is we have such a phenomenally talented and deep team that many of our executives moved out into regional roles to essentially act as infrastructure that doesn't exist. There were no people who were managing some of the things. So for instance, when the assessment centers went up, we co-led that with some others as well in some of the capacity work. So from a regional perspective, the talent pool that we have, the deep bench strength, we were allowed to repurpose some people who are very busy on a regular basis to be able to support some of those other things. In terms of the sort of the national and global and provincial stuff, I can't be prouder than just listening to Dr. Doug Fraser and the work that we're doing, and understanding that we really are a world-class academic health sciences center. So not only do we provide great care, but we're really pushing the envelope on some of the things that other places in the world are struggling with. And some of it's formal research like this. Some of it is less formal. I remember early on, not early on overall in the world, but for us, a few weeks in, there were some papers that came out about maternal child transmission of the virus, perhaps transplacental. And I was all excited about it. And they sent the paper on to Victor Hahn, who leads our neonatal intensive care. And he said, well, thanks for the suggestion, but we've been getting together with people from all over North America and the world talking about this for a month and a half now. So I was late to the party. It wasn't something that's necessarily going to get published, but our teams were already doing it, using ultrasound to diagnose COVID, to be able to look at the how much essentially fluid there is, pulmonary impedance there is in the lungs, to diagnose it. So, you know, we're really pushing the envelope. It was said when I went to school here 35 to 40 years ago that we punch above our weight class, and I'm confident and comfortable that in fact LHSC continues to punch above its weight class. And I think that this current crisis has really shown how impactful and how significant that work is. I'm very proud of Dr. Fraser and his colleagues for the research that we do.
And Dr. Woods, just to wrap things up here, I mean, you got to be very proud of everybody, and you got to be proud to be affiliated with LHSC from what you've heard tonight, and for what you know as even being a patient just a few weeks ago.
Yeah, and hopefully you can see me puffing up my chest with pride. That's absolutely right, Nick. And so just in wrapping up from our perspective, I would like to reassure people that the tragedy of COVID, so we're presenting an optimistic viewpoint, but the tragedy of COVID, people died. People died right in our city and some of our care homes and that. Some people have lost their jobs. Some people have had financial disaster. We're going to learn from what this crisis and this tragedy brought us, and we're going to build something better coming out of it. And I got asked, what things will we see different? I'm going to reassure the people listening to this and the people that we serve that things will be different and better on the other side of this. Carol alluded to virtual care. This is not just a stopgap. We've been trying to do this for 30 years and we can't seem to get it going. Well, we got it going in a hurry, and we're going to understand what was better for patients, what do we need to continue, what do we need to invest in. So virtual care is here, and I'm determined to make sure that it rationally and logically stays. Second thing is how we use our resources. We have a very fixed funding envelope. Ontario is not exactly rolling in cash. So how do we sort of determine which is more important, the total hip or a vascular procedure? I don't know that it's going to be the doctor doing this one versus this one. We're going to have a better way of understanding how we use our resources. And I think the third thing, and this is something I'm very committed to, is how we work together as a system. People talk about the Ontario health system, but it's not really, it doesn't act as a system in terms of sharing and that. Well, we have over the last few months, and we're going to, my commitment is to make sure that now that door is open, I'm shoving my foot in it, and we're going to keep going with that. I'd like to end from my perspective by thanking all of the donors, the ones who have traditionally supported us and have been generous through this time, new people who felt compelled to do that, and as what was alluded to by Neil, even the things like the painted rocks or the lights in the hotel downtown. I don't want to say which one I think it was because I don't want to get it wrong, but the big heart that it was about, I love healthcare workers. I can't tell you, and I actually saw that because I was in the hospital, by the way, looking up to the north. And I can't tell you how proud that made me. I also want to express my gratitude to the physicians, to the nurses, to the RTs, to the PTs, to the OTs, to the porters, to the food services people, to the custodial staff, everybody who is acting with courage and commitment and professionalism to serve people during this crisis. But in doing so, they're showing us how they really feel about the sanctity and the sacredness of the work they do, how important it is. And I put my plea out to the community. My family is in the US, and I think Americans have decided that the pandemic is over because they're just taking their masks off and going out to mass congregate settings. It's not over, so please help us by being smart. And I don't think that means hiding in your house. Please put masks on. Please wash your hands. Please don't get to big group hug mass gatherings and that. Try to help us, no matter what comes next, whether it's a big second wave, to manage that by keeping down that transmission, and help us to do as well, and I mean us as in Ontario and Canada, as we have done historically over the last few months, for whatever comes next. And again, thank you, Nick and the foundation and everybody on this call.
All right, thank you very much, Dr. Woods. And yes, we have to help each other to get through this. And as we wrap things up, I'm going to throw it back to John. But before I do, on a personal note, so proud again to be a part of this morning, and so proud to be a part of this community with our hospital systems. I just, on the personal note, my son's partner, they live with us, my son and his girl. Alyssa Pandolfo, is a nurse in cardiology at UH. Every night when she comes home at 7:45 or in the morning at 7:45, we stand up and give her a big round of applause. So to all the staff, and I'm going with you, Dr. Woods, the porters, the secretarial staff, administration, and especially, of course, the doctors, nurses, and everybody involved, and the foundation.
Thank you very much, Nick, and thank you for taking the time to do this. It's been a great hour. I can't believe the hour is over already. Lots of great information from lots of wonderful leaders here at the hospital. I think we could all agree that we're in great hands here in London, Ontario, thanks to the hard work of our hospital team and our frontline workers and everyone else who's been involved with this pandemic. And I also want to say thank you to you as community members for supporting us throughout this pandemic. And I know that, as I said at the beginning, it doesn't surprise me because this is what we do in London. We support each other in these times of need. I also want to give a quick shout out to the people behind the scenes for this. This is our first virtual forum of this kind. And depending on how restrictions go, we may do more of these. If the feedback from you as our audience is interested, we'd love to do this again. But thank you to Shannon, Neil mentioned Shannon earlier, Justin and Lindsay, who are on mission control, ensuring that this goes smoothly. And I think it's safe to say that it went very smoothly, and thanks to technology. So without further ado, we're gonna say goodbye for today, and we wish you all a great day. This is fabulous weather. Please enjoy. Nick, again, thank you for your moderation and for being a partner with us in this. Thank you, everybody, and have a great day.